So I want to spend a little bit of time talking about this case control study and talking about what we learned from reading the article about the risk factors for defaulting from TB care in South Africa. So our background information: South Africa has a high and increasing rate of tuberculosis, and TB is the leading cause of death in South Africa. There are low treatment success rates for tuberculosis, and default rates are high, and there is little information about why people default. So then what was the primary objective for this study? What were they trying to do in this study? So they're looking for patient level and provider level risk factors for defaulting. Okay, so a risk factor is something that puts you more at risk for having the outcome. So what factors of the patient makes them more at risk for defaulting? What factors of the patient or the provider make them more at risk for defaulting? There was an eligibility criteria for everyone, and there was a little bit confusion about this. So they had to have been on TB treatment, and it could have been either new or retreatment. It didn't matter. They had to be 18 years or older, and they had to have had at least 4 weeks of treatment. So everyone in the study had those criteria. Remember, you want to have your cases and controls as similar as possible. So everyone in the study had been on TB treatment for at least 4 weeks and be 18 years or older. So how did they define the cases? Who were the cases of in their study? Patients who defaulted, defined as what? What was their definition of default? So you'll find different programs have different defaults, so what was their definition of default? So those who stopped treatment 2 or more consecutive months. So who were the controls? So completion, cure, or failure were the controls, and they excluded those who died and those who transferred out. Okay, those who died or transferred out were not included. And you'll see this a lot in studies where I had a patient on TB treatment in Rinkwavu. They went to Kigali for treatment. They transferred out. When they got to Kigali, I don't know if they defaulted, and I don't know if they were cured. I don't know because they left, and so I can't include them in my study. Or for patients who died, if they had not died, I don't know if they would have defaulted or if they had failed treatment. Maybe they died from some other cause. And so I don't include them in my study as controls. They also can't include them here because they go and they interview them for more information, and they wouldn't have been able to get that information from those controls. So when they wanted to choose individuals to participate, they randomly chose health facilities. So maybe they made a list of all health facilities in South Africa, and they closed their eyes and they chose some health facilities. And at those health facilities, they chose one patient who defaulted. And for everyone who defaulted, they chose 2 people who had not defaulted. So who had either been cured or failed or had completed treatment. They identified the cases and controls based on chart reviews, and then they actively traced them in the community to do interviews with them in the community. So they wanted to know how satisfied they were with care. They couldn't get that information from the chart, so they had to go into the community and find these individuals. So types of data collected. I'm not going to go through all the variables, but remember they're asking in this study provider and patient level factors related to default. And there were 5 domains of adherence that they looked at. So socio and economic factors, patient-related factors such as education levels and family marital status, Condition-related factors, how sick were they? Did they have any co-infections? Therapy-related factors in terms of side effects, and then healthcare and health system-related factors. So they had a whole set of factors around, did you like the provider at the clinic? Do you think that they treated you respectfully? And those questions fall into the healthcare team and systems-related factors. And to look at the relationship between those 5 factors, or those 5 domains and defaults, they use a logistic regression model. A logistic regression model. So you should see in the analysis section of the methods where they say they looked at the risk factors for default using a logistic regression model. In logistic regression models, when they use that for analysis, they're going to look at the relationship using odds ratios. So anytime you see logistic regression, you're going to see the word odds ratio all over the results. And we're going to talk about now what is the relationship, how do we use odds ratios to assess the relationship between exposures and outcomes. So I'm going to start with this. Let us assume that there is no default, there is no relationship between default and home country. Now home country is, I've just chosen it as a random exposure, okay? This is my exposure of interest. You could have put gender or education level or marital status. I'm just interested in home country as an example of an exposure. So let's assume that there is no relationship between defaulting and where you are from. If that is true, then the proportion of patients who were from South Africa and are defaulted, given that they default, is equal to the proportion of patients who are from South Africa and those who did not default. So I have my defaulters and I have my patients who did not default. And if there is no relationship, then the number who defaulted, the number who are from South Africa and those who defaulted will be the same as the number from South Africa and those who did not default. So I have my group who defaulted, and I had my group who did not default. And if there is no relationship between those who defaulted in the home country, then the proportion from South Africa and those who default is equal to the proportion from South Africa and those who did not default. So I'm going to complement that with this picture. So again, remember we have cases and controls. Okay? And some of our cases are from South Africa, and some of our controls are from South Africa. And if there is no relationship between being from South Africa and being default or no default, if there is no relationship, then the proportion from South Africa here will be equal to the proportion from South Africa here. If there is no difference between being from South Africa and being a default and being from South Africa and being not a default, these proportions will be the same. Okay? The proportion from South Africa who defaulted, the proportion of people who defaulted from South Africa is the same as the proportion of people who did not default from South Africa. And the way that I differentiate from these groups is the proportion from South Africa given they defaulted is equal to the proportion from South Africa given they did not default. Okay? These proportions will be the same between the two groups if there is no relationship. If there is no relationship, the proportion from South Africa should be the same in the two groups. Now there is another way that I can write this. So this is writing it as proportions. The proportion from South Africa in the defaults is equal to the proportion from South Africa in the no defaults. This is another way that I can write it, where I look at the proportion divided by 1 minus the proportion in the defaults, and the proportion divided by 1 minus the proportion in the no defaults. If these two things are the same, then these two things will also be the same, right? If this thing and this thing are equal, then that means this ratio and this ratio will be equal. So if the proportions are the same in both, then these two numbers are the same, and this is called an odds. P divided by 1 minus P is an odds. So if the proportion in the two groups are the same, then the odds in the two groups are the same. The odds of being from South Africa in the defaults will be the same as the odds of being from South Africa in the non-defaults. And then we have this additional quantity called the OR. And this is the odds ratio. The odds ratio is comparing the odds from being from South Africa in the cases to the odds of being from South Africa in the controls. So the odds ratio is comparing the odds of being from South Africa in the cases divided by the odds of being from South Africa in the controls. So let me ask you a question. If there is no relationship between where you are from and defaulting, that means the proportion from South Africa are the same in defaults and non-defaults, and the odds of being from South Africa is the same in defaults and non-defaults. So what does that mean for the odds ratio? What will the odds ratio be equal to if there is no relationship between where the person is from and them defaulting? It will be equal to 1. And remember, generally when we look at ratios, if there is no relationship, then we will look at ratios, the ratio will be 1. Logically, this is what we're calculating. This is what I just showed you. What is the odds of exposure comparing cases and controls? In a case control study, this is what we're calculating. What is the odds of being from South Africa comparing defaulters to non-defaults? What is the odds of being male comparing defaulters to non-defaults? What is the odds of having high education comparing defaulters to non-defaults? Technically, that is what you are calculating, what you are interested in, because you're comparing your cases and controls, right? Those are your groups. Really, the way that we think, and really what we're interested in, is not the odds of exposures comparing cases and controls. Really what we're interested in is the odds of outcome comparing exposed and unexposed. So this is really what I'm interested in, which is the odds of the outcome comparing exposed and unexposed. So what is the odds of defaulting comparing people from South Africa to people not from South Africa? What is the odds of defaulting comparing men to women? What is the odds of defaulting comparing people with high education to people with low education? That's really what we're interested in. Technically, this is what we're calculating. Really what we're interested in is this. And the good news is that they are mathematically equivalent. It's actually one of the benefits of using logistic regression for case control studies, is what we're actually calculating and what we really want are the same thing. Okay? So what you'll see in the study is not this. What you'll see them reporting is this. What is the odds of defaulting, the odds ratio of defaulting comparing men to women? What is the odds ratio of defaulting comparing young to old? So that is what they are reporting in the study. but they got it from looking at the same logic that we had before. Odds ratio equals to 1 means there is no effect. There is no effect. Odds ratio bigger than 1 means the risk in group 1 is greater than the risk in group 2. Your odds of defaulting in group 1 is higher than your odds of defaulting in group 2. And an odds ratio less than 1 means your odds or your risk in group 1 is lower than in group 2. So if you see an odds ratio less than 1, that means your odds in group 1 is less than or lower than your odds in group 2. You have a lower risk. This just shows you who has a higher risk and who has a lower risk. It does not show you significance. It just says who has a higher risk, who has a lower risk. But it does not show you significance. What do you need to see to be able to say anything about significance? What must you look at to be able to say if it is significantly higher or significantly lower? Two things. P-value or confidence intervals. Okay? So this will tell you higher or lower, but it does not tell you if it is significantly higher or significantly lower. To do that, you look at p-values or confidence intervals. And p-values are easy. You look at 0.05, and if it's less than 0.05, fine, and if it's bigger, then it's not significant. Confidence intervals are harder, so we're going to look at confidence intervals. Which set of confidence intervals, A, B, or C, which set of confidence intervals would you say are significantly different between the groups? So remember, an odds ratio equal to 1 means no effect. So which, say again? B and C. Excellent. See, I told you if you stayed with me for a while, you would start to get it. Okay? These ones are significantly different. If I see a confidence interval covering 1, I don't know what the truth is, but I think the truth is somewhere here, and it's possible the truth is 1. And if it's 1, then there is no difference. Okay? But these, there's nothing covering 1, so I say they are significantly different. They have 3 tables that look the same. One is on socio and economic factors, the other is on patient factors, and the other is on clinical factors. So this is the one on socio and economic factors. They do 3 sets of analyses. They look just at new patients. They look at retreatment patients, and they look at them combined, new and retreatment together. And for right now, I want us to just look at the combined. They have odds ratios in AOR. The A stands for adjusted odds ratio. So they have the odds ratio for the combined, and they have the adjusted odds ratio combined. So remember, the odds ratio alone just looks at the exposure and the outcome. The adjusted odds ratio controls for confounding. The adjusted odds ratio has these outside factors that it's potentially controlling for. So it is controlling for confounding. It is minimizing that outside factor and the bias that's introduced if you do not control for it. So in this case, I really want you to focus on only the adjusted odds ratios, the things that are controlling for potential outside factors. And when you look here, you'll see for this exposure, country of birth, you will see an odds ratio. Okay? You will see an odds ratio for the Republic of South Africa. And you will see nothing in the one underneath it, which is outside of South Africa. So you see a number in the Republic of South Africa, but you see nothing in the cell underneath. That means they are comparing the Republic of South Africa to people who are not from South Africa. So this is the odds ratio comparing default in people from South Africa to people who are not from South Africa. This is the odds ratio comparing default in people who practice religion to people who do not practice religion. Based on that, I want you to look just at the adjusted odds ratios. I want you to review tables 2, 3, and 4 and tell me what factors are significantly associated with defaulting for all TB patients adjusting for